Hi everyone, welcome to the Liverpool Dementia and Aging Research Forum this month. We have today a really interesting talk by Dr. Stephen Mason. He is the Research and Development Lead at the Palliative Care Unit at the University of Liverpool. And we have over 200 people registered for today, so really exciting numbers. Hopefully many of you will join us throughout. If you have any questions throughout this talk, please just post them in the Q&A and we will discuss them afterwards. So after Stephen's talk, we have about 15 minutes to ask him these questions and have a little bit of a discussion. So feel free to post them throughout. And if you are using social media, if you're using Twitter, for example, feel free to use our hashtag Liverpool Dementia. And now I'm going to hand over to Dr. Stephen Mason.
Okay, thanks for that, Clarissa. So I'm Stephen Mason. As Clarissa said, I'm the Research and Development Lead of the Palliative Care Institute, which is based at the University of Liverpool and which is part of a larger group, which is the Academic Centre for Palliative and End-of-Life Care, which is based at Luft and the university hospitals. And again, I'm going to talk a little bit about the study that we're currently running, which is looking at the experiences of end-of-life care during COVID. And as always with these types of studies, there's a big team that's part of that. And I've listed some of the team members there: Katrina Mayland, Rosie Hughes, Tabs McGlinchey, Kate Bennett, Warren Dunlin, Elizabeth Rappa, and Louise Dalton. And so for this talk, I'm going to give a little bit of an overview of how we've come to this study and where we've come from as a palliative care unit in terms of looking at COVID, and why this is maybe kind of useful for this forum, the Dementia Forum as well. When we know that COVID is a big challenge, I guess we constantly have daily updates on the numbers, and we know that it's about over 1.2 million people who've died with COVID. We know in the UK there's about almost 50 million deaths within the UK. And I guess for this forum, thinking about dementia and the impact that that has, we know there's over 800,000 people with dementia in this country, and there's about 4 carers for every 1 person, so that's about 4 million carers. And we know that roughly of the deaths that we've had in the UK, about a quarter of those are with people with dementia. So there are real challenges. Excuse me. And I guess what we're trying to do in this study is find out what's going on to try and document those experiences in a way which we can then look at how we maybe structure care moving forward. So just because I'm from palliative care, I'm not sure how many people know what palliative care is and what the focus of palliative care is and what its function is. So I'll just give you a little bit of a background to that and a background to our unit. So this is the World Health Organization's definition of palliative care, which is often used and often cited in talks around palliative care. And the key things within this definition are really about is a focus on quality of life in palliative care. So it's on quality rather than quality. And palliative care is very much an active care. Often people think palliative care comes in at the end of illnesses, or where people are maybe going through potentially curative treatment, and then when nothing can be done, or when people sometimes hear that phrase, which they shouldn't hear, palliative care comes in. But palliative care is the care which can be integrated much earlier in people's illness experience, and actually brings lots of benefits with it. A very famous study conducted almost 10 years ago in the States by Jennifer Temmel was looking at patients with lung cancer. And she was very interested to look at the effects of palliative care integrated early with patients with lung cancer and the effect that had on quality of life. And as you might expect, it improved quality of life. But one of the things they also found as well was that having palliative care integrated early in the illness process for people actually improved longevity as well for people, and longevity with good quality of life. So palliative care can have multiple impacts. And again, palliative care isn't just one of those things which is bolted on at the end. Palliative care is everybody's business, is every healthcare professional's business these days. A recent study, or a study about 4 or 5 years ago by David Clark, based in Scotland, looked at all the large DGHs in Scotland to look at the patient profile. And effectively what they found is that at any one time, about 1/3 of the patients in any large district general hospital or university hospital are in their last year of life. And again, it's a different way to think about what our patient population is in the hospitals and whose role palliative care is. And palliative care really is everybody's business. It should be synonymous and synchronous with good quality medicine, good quality healthcare. And again, very much at the centre of palliative care is this idea that it's an approach which is holistic in its focus. And this was really kind of developed by the doctor in this photo that you might be able to see here on the left. And this is Dame Cicely Saunders. And Dame Cicely Saunders really pioneered and developed what's basically modern day palliative care. And she's a really remarkable lady. She originally trained as a nurse during the end of the Second World War, and she was a nurse, and she injured her back and couldn't continue nursing. And she retrained as a hospital social worker at that time. And she was very interested in the plight of dying patients and people who are at the end of life and how they seem to be ostracised by the healthcare systems. And she wanted to change that and affect different practice, but she was struggling to do that. And it wasn't until a colleague said to her, Cicely, you'll get nowhere unless you're a medic. The healthcare system is run by medics, and medics have all the power. So having trained as a nurse and then as a social worker, she went back to college to train as a doctor with the sole intent of that when she qualified, trying to advance the science and the practice of care, which would help facilitate dignified and good quality care for patients as they move towards the end of her life. And effectively, it's been said before, she's effectively a one-woman MDT, bringing all those different elements, and all those different elements helped her conceptualize this idea of palliative care as a really holistic approach. And I like this photo a lot because you might be able to see the patient in this photograph is a lady sitting on the chair, but obviously one of the relatives is there and she's holding her hand. And again, the patient and family are very much treated as a unit within the palliative care focus and looked after together as a whole. And that's sometimes difficult to do, but that's really one of the aims of palliative care. And what Cicely Saunders did was she kind of really, when she opened St Christopher's Hospice in 1967, she developed, it was the first of the modern hospices which had really a three-pronged approach, which was high quality clinical care for patients and their families, a research agenda to develop the evidence base to improve care, but also an education strategy to take the lessons of the hospice to the hospital and to the community, so that the care that people were getting was a philosophy of care rather than the place of care that they happen to reside. And on those principles are the principles of the unit that I'm based in at the moment. So I'm based in the Academic and Palliative End of Life Care Centre. And again, we have a base within the Royal University Liverpool Hospital and also a footprint within the University of Liverpool. And in the University Hospital, we have two kind of clinical academic teams. We have a consultancy team who will travel around the hospital, and if they have patients who need support and guidance in terms of how their care is structured, the consultancy team will provide that information. But we also quite uniquely have an academic palliative care unit, which is a 12-bedded ward on 4Y. And again, this is quite a different ward to how the rest of the hospital is. It's only a recent development. It was only developed in the past 4 or 5 years. And you can maybe see from the pictures there, it looks quite different in terms of the reception area. And some people think of it as almost like a hospice in the hospital, and it's not quite that. But it maybe has that feel to people. And again, there's 12 beds, there's 2 4-bedded bays and 4 single rooms. And again, this gives us an opportunity to kind of look at the research that we do. And palliative care patients are really keen to be involved in research and take part in studies to try and help other people in terms of as we generate the evidence. In terms of the academic department as well, we have support services, and we have a very effective volunteer programme which provides support to patients and to their relatives as well. In terms of our academic outputs, we have 2 different teams. We have a learning and teaching team, and again, that does learning and teaching on palliative and end-of-life care and everything from CPD sessions up to doctorates, and we have a number of doctoral students who are part of our group. And then there's a research and development unit which I kind of lead, and again we have studies which range from bench to bedside. So we have some researchers who are looking at the different drugs and how they maybe interact when they're used in syringe drivers. We've got one chap who's doing some novel and innovative stuff where he's looking at urine samples and identifying compounds within those which may be prognostic indicators, to the more patient-focused, qualitative experience elements. So we have a wide range of research that we kind of engage with. And that's important because palliative care is an area which needs evidence developed, and it's a global challenge. This is some information from the Lancet Commission report in 2017, and it's estimated that over 40 million people are in need of palliative care, but less than 14% of people actually have access to good, structured palliative care. And the consequence of that is avoidable suffering. In the Lancet Commission report, the notional hours in terms of suffering that can be avoided is documented there in the slide for you to see. And again, if we can have structured good quality palliative care, it can impact on the challenges that patients and their family face. And as part of that approach, our team in Liverpool here, we actually lead a group which is the International Collaborative for Best Care for the Dying Person. And that's a 24-country collaborative, and that involves South America, North America, Eastern Europe, Australasia. And the aim of the International Collaborative is to try and advance best practice and to develop the evidence base around that practice. Now, there are lots of different research groups doing lots of really interesting work in terms of palliative care, but our collaborative, we like to focus particularly on care in the last days and hours of life, and that's really our special interest, and that's our special focus. That doesn't mean that we don't look what happens prior to then, because often what happens early can have an impact on their experiences of care at the end of life. But also it means we don't ignore what happens beyond death as well, in terms of the bereaved and the experiences that they have and the way that we can try and support them. So part of our aims to try and help contribute to the evidence base, we were lucky enough to secure some funding from the EU from a funding stream which is H2020. And this study is being led by a team from Erasmus University in Holland, and we're part of what's called the iLive study. And this is an ambitious study which is looks to try and document the experiences of end-of-life care for patients and their families, to try and show what effectively the quality of dying is like. And there's 13 countries involved in this, and what we're hoping to do is create a data set of almost over 2,000 different patients' experiences across these different countries, to look and see where there are similarities, but also to try and look and see where there are challenges and areas that we can improve upon. As well as this large cohort study, which is a 4-year study, there's some complementary studies associated with it. So one is a digital medication tool, which we're looking at ways we can de-prescribe towards the end of life. Often when patients are nearing the end of life, they're still on multiple medications. And one of the things we're looking to do is see how can we safely de-prescribe and stop people having the burden of taking tablets and medicines. I mean, they maybe probably don't need to, and maybe are of little or no benefit to them. Another project that we're doing is looking at volunteer training, and we have a very successful volunteer program in Liverpool, and on the basis of that we've developed a curriculum which we're piloting in 5 other countries to look at how volunteers can provide support in the hospital setting. And we're also developing a core outcome set, which is basically a way to try and stratify the measures that we use to assess the quality of care at the end of life. And that's really so that when we're generating evidence, we can have transferability across studies, so that we know that when one group are reporting a set of data, that we can match that with our data and look for comparisons. So we got this funding at the beginning of 2019, and you see there's a picture of us there in a very cold Rotterdam. And we were all excited and getting ready to go. And we spent 2019 developing our study protocols and getting ethical approval in place and employing our researchers. And we were pretty ready to go with our study. And then, of course, COVID happened. And again, it's just interesting to have a look at the timeline of COVID and what's happened since those early days in January. You can see here, there was these first notions and first reports of the challenge of this virus and being reported in China and what was happening. And again, I don't know if you can see in these clips from these newspapers and from the BBC website, these are reports from January, and the idea of this mystery illness. And interestingly, the World Infopic there is about the spread of cases of coronavirus outside of China, and that's in January. And you can see the figures, they're double digits and single digits in most countries. But things, as we know, progress quite quickly. And there's a really interesting timeline available on the World Health Organization's website. And again, I'd encourage you to have a look at that. And you can see there the first notifications around the coronavirus in China, and to almost 12, 13 weeks later, just 2.5 months later, the WHO declaring this a pandemic, and here in the UK is moving very quickly into lockdown. And you can see on that second picture there already the blue bar graph there, the increasing number of cases and increasing number of deaths which are being recorded attributed to coronavirus. So it's a very fast pace of time, 10 to 12 weeks from this mystery illness is reported in the newspapers to this pandemic. And again, within the news, we'd already seen pictures from Italy and from China of the challenges around coronavirus. And this started to happen and be replicated in the UK as well, and particularly around the time of lockdown. And there was already reports of the challenges in terms of providing care and about capacity for clinical staff. There was the challenges with the PPE equipment for staff in the environment who were trying to provide care. There was the issues already about communication with patients and people not being allowed to see their relatives who are COVID positive, issues around what's already happening around bereavement, issues for staff and for people in the community who were shielding, impact on bereavement rituals. And so again, there are already reported in the popular press lots of these effects. And at that time as well, with our study, we were told to stop all research in Liverpool and across most of the UK, unless it was COVID focused. There was a hold put on research activities. And that was really to enable researchers to really repurpose what they were doing and really for a lot of the bench-based work to look at developing vaccines and developing interventions to try and help and support patients. So we were in a position where we had a number of protocols developed, a composite questionnaire. We had research staff in position, and we were stuck because we couldn't continue with our study. So the Dutch team who are leading the ILIV study, we had some discussions with them, and very quickly thought, well, we may as well use this time and use the research protocol we have to look at these experiences and to document them. And it meshes very closely with what our study was, and to look at the experiences of end-of-life care during the COVID-19 pandemic. So after a bit of work, the Dutch team repurposed the questionnaire, and we inputted on that. And we developed an online questionnaire that we were intent to spread out and to survey people in an open way rather than targeting specific groups. And to try and look at some of the challenges that were being faced. So we had a questionnaire which looked at quality of care at the end of life, the emotional state of people, the issues around support, and that was support from the clinical sector, but also support across their existing support networks, to look at the issues around communication, to look at resilience and the impact of the normal coping strategies that people may have, and then demographic questions around hold on, Rudy, stop singing. Rudy. Sorry, right. So this was an open online survey. We'd structured it, and to do that, we used the license from a Qualtrics platform, which is a way to host questionnaires from the psychology department. And again, the idea for this questionnaire would be for bereaved relatives and for healthcare staff. And accessing the Qualtrics platform from the psychology department is really quite fortuitous because it helped develop some of the collaborations that we've now got. in using the platform, we contacted the psychology department to see if any of the team there would be very interested in what we were doing. And again, so we were joined by Prof. Kate Bennett and Dr. Warren Donnellan. And again, Kate has a real interest and experience in bereavement and in widowhood. And Warren's got a real focus on long-term conditions and the issues of resilience and ecological understandings of resilience. And very shortly after we launched a questionnaire, we were contacted by a couple of researchers from Oxford who are very interested in the experiences of children during COVID and what information children have been told, particularly whether healthcare professionals were prompting people they were speaking to about the discussions that they would potentially have with children, and actually how those people who've been bereaved were able to disseminate that information amongst children as well. And again, when you go back to the original, the definition for palliative care from the WHO, you can see that, you know, palliative care is for patients and for children as well. So in terms of what we then did in terms of a procedure, so we advertised the questionnaire online through Twitter and through different interest groups. To really just try and throw this out there and to allow people to contribute what and how much they wanted to. So we started in the summer and we had an initial 3-month recruitment window. And what we also had within the questionnaire as well is that we allowed people that if they wanted to, they could nominate themselves for a follow-up for an interview to provide more depth on the data that provided with the questionnaire. And they could nominate themselves to complete a follow-up questionnaire in 3 months' time, because we're interested in what happens long-term in terms of the effects. And again, because this was developed from our ILIV project, there's parallel studies going on, not just in the countries that were engaged in the ILIV study, but a couple of other countries have joined as well. So one of the things we're really potentially interested in is how the data that we're collecting matches up with data from other countries in our group. So I'm going to just talk a little bit about some of the results that we have, not the full results, it's just some of the interim data that one of the members of the group, Warren, pulled off for us, which we engaged a while ago. So in terms of survey access, we had a lot of traffic in terms of online access of the survey. So there's over 2,000 times that the survey was accessed, but not all of those people who accessed the survey actually completed the questionnaire, and we reckon we probably got about over 750 kind of entries which are probably workable data that can be meaningful. And we have a lot of missing data, and that's partly because of the approach that we used in collecting the information. We didn't want to force response the questionnaire, which means that people in completing the questionnaire online had to complete a question before they moved on to the next question. We realised that some of the questions may be potentially difficult for people to answer, and we wanted to give people the opportunity that if they didn't want to answer questions, they didn't have to, but allow them the opportunity to provide us with data that we could make sense of. So we have a bit of a workaround about how we're going to make sense of that data. So what I'm going to report on here is just the first 500 or so data points that we have. In our survey, we had a roughly split of between 70% from healthcare professionals, 30% from bereaved relatives, and that's balanced out a little bit more subsequent in terms of the additional data that we have. In terms of gender split, there was largely female compared to male and then non-binary, and in the bereaved relatives, that was even more so the case. So about 86% of the bereaved relatives were female who were answering our questionnaires. And again, there's a potential bias in there in terms of our results. In terms of the age range of those completing the questionnaire, you can see that there. And in terms of the range of those who were deceased, again, you can see from 22 to 103 with mode points there. So in terms of the relationships to the disease, I'm just going to focus on the bereaved relatives for this presentation today rather than go through everything we can. So you can see here that the majority of people who completed our questionnaire were the son or daughter of someone who died. Again, there are a range of different kind of relationships there, but yeah, son and daughter was tend to be the predominant. In terms of where people came from, most of our data has come from England. There's a rough comparable in terms of you're looking at populations between Scotland and England. So we've got a decent representation from Scotland. So these figures you can see here, these are percentages. And about small numbers from Wales and Northern Ireland. And now there were already surveys already being undertaken in Wales and Northern Ireland. And again, this may be one of the reasons why we've struggled to recruit from there. But again, it's an open online survey, so it's up to people to contribute if they could or they would. In terms of place of death, you can see the range there. So a number in a hospital and in different units within the hospital. You can see there in terms of other, there's quite a large percentage of other, and that's actually individuals' own home. So again, a spread across where a place of death occurred. In terms of the illnesses that are associated with the death, so we weren't just looking at particularly people with COVID, we were looking at any death that occurred during COVID, because often the restrictions that were happening were impacting on everyone within the healthcare setting. So within the hospital particularly, restricted visiting and issues around PPE were challenging, so not just for those people that were COVID, but also in other areas. And you can see the spread there. So again, the majority of our respondents with cancer, then heart failure and dementia, again, a large number from dementia. And again, that represents kind of the national profiles. So in terms of whether the person who died had COVID or not, we asked people whether the bereaved relatives, whether their loved one had COVID. And you can see here, it's probably about 2/3 thought that they did, to 1/3 that they didn't. So although we weren't specifically looking at COVID, we have a large number of our data is from people who were COVID positive. What we wanted to find out as well is we were very interested in what the communication was around care at the end of life, and we were interested in whether the relatives were told that their loved one would die soon, but also whether they were told what to expect in terms of what symptoms might have or what might happen generally, or what the experience might be like. And again, encouragingly, we could see that most people were given information and helped to prepare through that by being told that their relative would die soon. But again, there's a lack of information about what to expect and what might happen. So there's a bit of disparity there in terms of people getting that initial information about what was happening, but not what to expect. In terms of visiting, again, there's a split roughly, it's almost half the people who were able to visit in the last couple of days of life, just under half were able to, but the majority, just over the majority here, not able to visit in the last days of life. And again, when we're thinking about the impacts and the experiences and what impact that may have on bereavement, that's quite a big factor. Again, we were interested in the quality of care that people had, and so we asked were they treated with respect and dignity by doctors and nurses. And again, we can see here that for the majority of people, the experiences were that their loved one was treated with dignity and respect. But again, as always, there's some concern. There are some people who raised some concerns that that wasn't the case. And again, we were interested in support as well, and what support they had from the healthcare team. And as healthcare teams are battling with the challenges of COVID, what they were able to provide for the relatives. And again, you can see here that there's a good number, just the majority that were able to have some, felt that they were given enough support. But again, a large proportion of people who felt that they actually weren't given support that they would have liked, or perhaps would have expected. And again, as with quantitative data, it's always hard to kind of make sense of these numbers and what they mean. So we have conducted interviews with about 25 or 26 people to date, and I'm just going to go through some of the stories from the bereaved relatives that we've got and the themes that have come out from these interviews. So communication is a big issue, of course, and again, it's something that we see in the popular press. And again, these are just I'm just taking quotes from three of the interviews that we've done with bereaved relatives, just as a way to kind of give you a flavour of some of the things that crop up. And we can see here from one of the respondents, they talk about they felt they got a lot of communication from the clinical team, and the clinical team were available for that information, and they felt that actually they were getting that information. Equally, from the respondent 8 that we had in terms of the interviews, you can see some of the challenges that they're talking about of speaking to healthcare staff, and if healthcare staff are in PPE equipment and struggling to hear and make sense of what's being said, and struggling to kind of pick up those nuances and wanting to make sense of what's happening to their partner, but not being able to. Visiting, again, within the last data that we were showing there, was a big challenge, but again, it's different for different people. So for first respondent here, they didn't, even though they were trying to get access to see their husband in the last days of life, they ended up not going because of their concerns about having to then self-isolate and the people that they had to provide support to. So again, there's some real challenges for people which are going to have impact on how they make sense of what happens post-bereavement. Again, from respondent 11 here, talking very much about how actually, because they were able to go and see their mother in this case, who was in a care home and the mother had dementia, of how that was really useful for them, and being able to interact and kind of actively care for their mother. Again, a bit of not such a good story. Again, this was from someone whose husband was in the hospital and in a COVID ward, and trying to see their husband and trying to be able to go and see them, but again, waiting for this phone call and being told they can only be invited when it's end of life care. And this is over a period of days, and then having to go in at the very last minute, and you can imagine the effects that something like that will have. In terms of support, again, there's a range of experience of support. Again, from the first respondent here, they're talking about their the challenges and who they can provide support to, and the support that they got from the hospital, and again, feeling that the hospital had done everything that they can in challenging circumstances. Again, from the second respondent here, this was after their husband had died, and not giving any further information, and giving a phone number to call for bereavement support on a piece of cardboard. And again, the impact that must have on someone in terms of trying to navigate their feelings and the sense of importance that they get from that. And again, for the last respondent there, talking about the challenges within their family and being able to see each other and discuss and the normal support mechanisms that people would have, and the normal interactions that people would have, and being compromised because of restrictions around COVID. Again, in terms of place of care and where people were being cared for, we had a range of places where people were cared for, and again, we didn't get too much feedback that places of care weren't appropriate, and it was related very much to the clinical conditions of the people who are being cared for. But again, you can see the variances here between the first respondent being happy where their husband is being cared for in terms of being cared for in the hospital, and then the last respondent there about their mother in the care home, and that was a place where she'd been, and that was effectively the lady's home, so familiar for her and a place to be. Again, the restrictions were a big theme in the interviews, and particularly around the normal bereavement rituals that people would have, and which help people adjust and adapt to their new realities as they face them. And again, here, the first respondent again talking about the restrictions around the service, but being able to integrate that and thinking that the rules are there to protect people, so be able to kind of appraise that in a way which allows them to assimilate and take that information. Again, from the second respondent there, talking about the normal rituals that they would have, about having the body at home and being part of that wake process, and not being able to do that, and the impact that will have. And similarly, even for the the last interview person here, whose experience was largely well managed. Again, just the interruption of those normal bereavement processes and the impact again that will have. And again, one of the things that came out as well was the reflection. So these people reflecting on the challenges, but also just not the challenges, but the causes of those challenges as well. And there's quite a bit of anger and upset at how things were being handled, not by the healthcare services, but I guess by effectively the government's response into this. And again, you can see from the first respondent there talking about a lot of anger as to why it happened and how it happened, and feeling that maybe things could have been avoided. The second respondent there was talking about an experience where she'd seen a presenter on TV whose husband is COVID positive and being cared for, and again the differences in her experience to that she was seeing on TV. And I guess this is a real challenge for people, is that people are navigating their grief and the challenges that they have in a very public experience of this public pandemic, and the constant information within the news, which can often make it tricky and difficult for people to make sense of their own feelings. And again, the last respondent there talking about the challenges of being upset and with a colleague who would normally provide them with support, but because of restrictions, not being able to engage in those normal processes. So that's just a kind of a quick overview of where we are, and we're still working through the data, and we're still carrying on our study, and we're into the second phase of our study. But I guess what we can show so far is that, that, as we would expect, providing good quality care for patients and their families is challenging, and it's challenging for the families and for the patients and for the healthcare staff as well. From looking at the bereaved relatives who've taken part in a survey, we know that majority knew that the person that they loved was in their last days of life, but their knowledge around what was happening and what was going to happen was limited and potentially problematic in helping them adjust to what was going on. Majority weren't allowed to visit that person, but many of them had access to iPads or tablets to kind of speak, or telephones and communicate with the relatives. But equally, again, it's good that the majority of people felt that their loved one had been treated with dignity and respect by the clinical staff. But the key thing is we know that support could be better. And again, there's some interesting work which is going on. There's a really nice systematic review published by Emily Harrop and the team in Cardiff, where they've looked at the experiences of bereavement in national crises and in national tragedies. So things like the 9/11 in the States, or the tsunami. And again, one of the things they've found in their systematic review is that people aren't very good at accessing support. And actually there needs to be a proactive approach to enabling people to engage and find the support that they need. So again, the next step, so our study and our analysis continues. And again, as I say, we're really trying to do this to look at ways within the clinical sphere that we can try and improve things, and support is one of those areas which has come up as a big challenge. We're working with the Lancs Clinical Trials Unit and the data that we have, and looking at the missing data and how we can make best sense of that. We have a longitudinal follow-up of those people who completed the first part of the questionnaire, and we're sending out follow-up questionnaires to people now, and we're collating that data. We've got the international comparison that once we have our data complete, we'll start to look at and compare and see where there are similarities across countries, but also interestingly where there are differences. And I guess what we're hoping to do is add to what's already a developing field. And there are a number of really excellent studies which are ongoing, and which again I would encourage you to kind of have a look at. There's a really innovative piece of work led by Professor Simon Noble out of Cardiff, which is called COVID Confidential, and that's really for clinical staff. And it's a way for using the internet for staff to offload and to document their experiences in providing care. There's the COVPAL study, which is led out of King's and the Cicely Saunders Institute by Irene Higginson and colleagues, and that's looking at the role of palliative care services and hospices in providing support and care during COVID-19. And there's a new study, or a relatively new study, which has come out from the Cardiff group, again from Emily Harrop and Lucy Selman, which is looking at experiences of bereavement and support, and particularly for Black and minority ethnic groups and the challenges that those people face. And again, for us, it's just as always, it's a big thank you to the people that have taken part in this study. The questionnaires probably weren't the easiest things for people to go through, and then often in the interviews, people are sharing some really difficult times that they've had. But again, people have been keen to share those so that maybe a little bit of that information can help us maybe change practice in a way which maybe makes things further. So again, we're really thankful to all those people who took part in our survey and who provided information, because again, we wouldn't be able to make these advances with them. So thanks very much. I'm happy to kind of answer some questions if there are questions.
Thank you very much, Stephen. That's great. That was really interesting. So first of all, just to let everyone know, please use the Q&A chat box if you have any questions or comments or want to share your thoughts about it, and then we'll publish them as we go along through this Q&A. That's been really interesting, Stephen. Sounds like you've quickly adapted the hindrance of COVID and adapted your work to that COVID sphere.
Yeah, I think for lots of people in both in practice and in research, there's, I guess, there's the phrase that necessity is a mother of invention, and I guess there's been lots of innovation which has been developed, certainly within research, but certainly within practice as well. There's a very interesting presentation last week from the Cicely Saunders Institute where they were looking at the digital innovations that are taking place in terms of consultations taking place remotely, and how we're moving much more to digital formats. And there are challenges with those, but also there are benefits as well. So, and I think in the research field as well, we're having to learn to do more things online. All our interviews have been conducted remotely, either through Zoom or through telephone. And again, as an experience, that's it's not as good as a face-to-face interview, and it's often difficult to read someone's emotions. And but again, it allows us to maybe reach people who are more distant and reach people in different ways. So yeah, there are lots of developments and innovations.
Yeah, definitely. So about your study that you had to then adapt, is the iLive study, right? Have you or has your team collected any data before the pandemic that you could compare this to?
No, we were literally weeks away from starting our study when all research activity that was non-COVID focused had to stop, and so because of that, we have now just restarted that larger study, and we are the first recruiting people to that study. But again, yeah, we don't have that data prior to the COVID study to act as comparison, but yeah.
No, fine. I see quite a few comments trickling in here, so please keep them coming in. So looking at them, so we've got Helen Nixon is asking, did you feel that the isolation of persons with dementia contributed to the advance of their illness and eventual death?
I think, yeah, that's not something that we have specifically looked at in our study, but I know there's certainly work, and certainly Clarissa and the group in Liverpool have looked at that and shown that actually the challenges with isolation have exacerbated the issues that people, particularly with dementia, face, and the difficulties around access and support and changes to the normal experiences that people have. So I think there's developing evidence on that. I don't know, Clarissa, you're probably better placed to answer that question.
Yeah, Helen, we've done some research, some qualitative research in particular with lots of unpaid carers and people with dementia, and what came out, and that was back in April, so only a few weeks after the lockdown, is that carers, so family members and friends and neighbours, they did already notice that faster deterioration of the dementia symptoms because the relative didn't access social support, didn't go out, didn't get that stimulation. So I think it looks like it's linked, but yeah. Okay, so, and Dr. Sarada Kodali also mentioned we as a mental health group felt helpless as we knew our dementia were the worst hit. So there's definitely something around that. interesting talk. And then from Anonymous, we use tablets in the acute hospital to try and support communication between people who were dying and their loved ones in the initial stages of the pandemic when visiting was not allowed. This worked well with some people, but sometimes added to the confusion, again, of people living with dementia. Has anyone else found better ways of enabling communication, particularly if families live at a distance? Stephen? I'm
not sure that anyone's found better ways. I think it's people have responded as best they can. And again, in our survey, one of the things that we looked at was the digital communication. And I think for about a third of the people who responded from our bereaved relatives group, they said that actually the units or the wards where people have been cared for actually provided tablets and electronic resources to facilitate that communication. But equally, a third of the people said that it wasn't actually structurally provided. And again, I know that's something that healthcare services now are making sure is something that's more prevalent. But yeah, I agree. It's very difficult for people, particularly with cognitive impairment, to move from an experience or a modality to a different modality, and what that's like. So again, these are part of the information that we're trying to make sense of, to think, well, are there different approaches? And there may be, but again, I'm not aware of anything that people have come up and highlighted as a better way to try and bridge that gap.
I mean, we see that a lot in care homes as well, don't we, at the moment, that there's this lack of interaction, lack of visitation, sadly.
I know that within our group we've been looking at, so we have a researcher who's very interested in virtual reality as a therapeutic intervention, and there's a lot of work that's been done on people using VR headsets for guided relaxation and so forth. But there is some embryonic work which is looking at actually VR as a way to potentially, or augmented reality, to have almost people sitting in the room with them. And again, but again, that'd be something that's a project that's way on down the line. And again, for people with cognitive impairment, that would need to be very sensitively and trialed, because it could be potentially quite upsetting. So yeah, I think people are trying to think sideways about what other approaches we can use to bridge those gaps. But it's not moving. I guess it's not moving as potentially as fast as people would like.
Yeah, and along those lines as well, comment by Anonymous, I think the impact of COVID on patients and relatives is underestimated, and still the fundamental problem is lack of communication between secondary care and the relatives who are not allowed into the hospital unless the patient is deemed end-of-life care. But then you were saying as well in your survey results that even when people were end-of-life care, sometimes the relatives weren't allowed to see them, Stephen?
Yeah, yes, I guess our survey ranged from people like, and I guess hospitals have adjusted to that experience. So even within our own hospital, initially when we were in lockdown and the Royal was large, very large numbers of COVID patients, all visiting was largely banned. And again, our palliative care group had to kind of argue to allow people to come in, and particularly if someone's in the last days of life, to come in. So again, I think it's been shifting. I guess people have moved from a very cautious approach to one which is maybe a little bit more reasoned. But again, unfortunately, people have been caught up in that and maybe been denied access. So it's a bit of there's a range of experience, and again, I guess what we're keen on is the impact of that.
Yeah, talking about the impact and next step as well, we have another question from Anonymous again. Do you work with health trusts to implement those changes if findings in certain areas are supported?
Well, yes, of course, I guess that's what we're all trying to do, is we're all trying to look at the evidence and see if there are ways that we can improve services. And if we do find those, then we are trying to disseminate that information, and we can use things like the Applied Research Collaborative, for example, as a different ways when we have good evidence of things that can make a difference and make a change, then we of course will disseminate that. And again, there are a lot of local and small innovations which people make in terms of practice-based evidence, but yeah, we're trying to look and see systemically what changes are there that we could maybe affect, which may improve things.
Yeah, we've got one comment again on dementia, but I suppose it's just broader end of life care. It's about this advanced care planning and how important it is as soon as someone does have a condition that is deteriorating, that someone makes this advanced care plan as soon as possible, so that they and their relatives know what they would like in these final stages of life.
Yeah, and there are lots of different approaches, to advanced care planning. There's advanced care planning, which is the type of advanced care plan around decisions around interventions and treatment that people may want, particularly in the last days and hours of life. But equally, there's advanced care planning, which is more about people living their best life effectively. And this is one of the projects that we are hoping to develop with the Applied Research Collaborative in the Northwest, which is called the Serious Illness Care Project. And this is very much about empowering clinicians and giving them the skills and setting up systemic changes within the reporting material and the electronic patient records to allow clinicians to have discussions with patients about what their priorities and goals are. So not just about what treatment decisions they want at the end of life, but actually what people want to achieve with the life that they have and what they're aiming for. And that sometimes allows a different focus of care and a different, rather than care being reactive, care from the care services can actually be proactive and actually ensuring that people's aims and wishes and issues around toxicities of treatment and so forth can be avoided if that's potentially more beneficial.
Yeah. We've got questions surrounding any emerging guidance around pre-visit testing as part of the protocol for visiting and PPE, and if there's PPE involved, who supplies it, for example. Do you know that?
No, that's not something we've picked up in our study around that type of guidance. But again, I guess local trusts our trusts are developing their guidance as it's and adapting that as it's developed from the Department of Health. So yeah, but that's not something particularly that our study I think will particularly focus on. It may do. I mean, in one of the interviews, one of the participants was talking about the challenges of putting on PPE to go and see their partner and the difficulties with that, and not knowing what they can and couldn't do, but just finding the whole experience quite frightening and difficult, and not having any preparation for what that experience would be like. So again, that's one of the things that we can maybe take and think about, actually, if people are coming in and having to use PPE, that actually giving them some better information or preparatory information about that experience that maybe helps them, so it's not so alien and not such a thing that, and the person talked about how after that experience they felt as they were peeling off their layers of PPE, the just one alien experience it had been.
Yeah, and we've got one more question. Well, I've got a few more questions, but we have to kind of pick because of time. Will any of the positive changes that were made during COVID, or hopefully are being made during COVID, be kept and used post-COVID, do you think?
I would hope so, because I think that there will be innovations which are helpful, and certainly the innovations around remote consultations and the ability for teams to communicate, and certainly in one of the talks last week from the King's Group, one of the clinicians was saying that how actually through remote consultations it was actually really useful within the care home, because actually rather than having people come out of the care home and get dressed and go to, you know, come in to a clinic for a visit. You know, these consultations can take place remotely, and they could link in a family member as well, and they could be done in the comfort of the person's own room if that's where they want to be. So I think there will be some changes to practice which have been forced by COVID, which may actually kind of stay because it's adaptive. But I think the challenge we have is looking at the evidence around these to kind of see, well, are these changes actually, what are the benefits versus the costs? And again, I think that's a longer piece of work, and I think there'll be a number of pieces of evidence and research studies which will start to unpick the true impact of different changes in practice.
Yeah. Great, thank you so much. I'm mindful of time, but that was really interesting. Thank you for some really interesting questions as well from our viewers. Thank you very much, Stephen. Very interesting talk. And if we could just move on to the next and final slide, please. So thank you all for joining us. I hope you've all taken some learning from it and take this away with you. And our next webinar in January will take place on Wednesday the 13th, and we'll have Dr. Catherine Lord and Dr. Sadia Paveen from University of Bradford from the Dementia Research Centre joining us. And they will give talks on how home care training is provided for dementia, also during the pandemic, as well as how the care pathways for ethnic minorities are being adapted. So if I've posted the link in the chat box, and if you want to join us, that'd be great. But thank you very much for joining. Okay, goodbye.